A very good evening to one and all. Welcome back everyone to the MASA webinar series from the Faculty of Dentistry. So today evening we have one of the important clinical topics from two good speakers for today's evening. I experienced and the dynamic speaker from MASA University. So today we have a webinar on the clinical applications of cone beam computed tomography in dentistry. This is a kind of a clinical based the webinar for today's evening. I would like to introduce our first speaker for today. So this particular topic is basically covered by two eminent speakers, and I would like to introduce a senior most the speaker for today evening. First, I would like to introduce Professor Dr. Prabhakaran Nambiar, who is a consultant forensic odontologist, oral and maxillofacial radiologist. Presently, he is working as a head of the Department of Oral Biology and Biomedical Sciences, Faculty of Dentistry. So Professor Dr. Prabhakaran is an Adelaide University scholar who has been responsible to have introduced forensic odontology as a recognized specialty in Malaysia. In 1997, he was awarded a government scholarship to undertake postgraduate training in oral and maxillofacial radiology at the University of Western Cape Town, South Africa. He was then responsible in not only teaching, researching, and providing services in forensic odontology, but also in maxillofacial radiology. He also assists the Medical Radiation Surveillance Division, Ministry of Health Malaysia, in preparing legislations with regards X-ray radiation safety during medical and dental practices in Malaysia. So he will be presenting our first lecture for today evening, and then later we'll be having a presentation from Dr. Mansoor Sati. And then I would like to welcome Professor Dr. Prabhakaran Nambiar to enlighten us on the clinical applications of CBCT in dentistry. I would like to invite Prof. Prabhakaran first.
Thank you, Dr. Raghu, for the splendid introduction. All right, our lecture today is actually in two parts. I will be doing the technical side, and Dr. Mansoor will be doing the clinical application. So it's two parts. So it is nice to see two speakers. Now, I'm actually a maxillofacial radiologist, but at the moment I'm with the Department of Oral Biology and Biomedical Sciences. This is the MASA University. I think those who know that it is a sort of a suburban university, quaint, and it is in a green environment. And it actually started as an allied medical science university with medical college and the dental college, and subsequently it became a contemporary university with engineering, hospitality, and business studies, and so forth. Now, the jewel in the crown probably is the dental faculty, because it is only 14 years old, but it is one of the first private universities. In fact, it's the only private university which has got postgraduate training in dentistry. Now, not far behind is one of the strong component in the dental faculty is the radiology department. Now, if you look at this is a letter from the Director General of Health stating that MASA University can be a training center for dental surgeons for Panoramic and CBCT courses. Now, this is very important. Those who are buying the machines, all right, they have to undertake this course. And if they don't take this course, they cannot use the machines. So all dental surgeons will have to do this course. And we are quite lucky that we are the second university in the whole country to be given this permission. And if you look at the person down here, he is the Director General of Health, who is currently fighting the COVID pandemic in Malaysia. So he is the one who signed the letter allowing us to start this course. Now, not only that, this is the now participants, the various courses. The last 2 years, they have been doing these courses, both for Panoramic and CBCT, and we had quite a good turnout for each time we have these courses. Now, we also have done legislation controls, which is very important for the country because dentists do not know why they are having so many restrictions. So we did this, and it was just published last year. I mean, this year, from January to June. All right, the Malaysian Dental Council Bulletin. So this is very important to educate our dental surgeons on the importance of the use of X-rays during oral and maxillofacial imaging. Now, I've also been involved in the quality assurance program for the radiology program, dental radiology, right? So this is the manual that was, what has happened is the ministry wants the dentists to take courses, as continued dental development or professional development, and they are required to take courses. And we have created a draft for the enforcement later. Then later what we did was we also have been called up by the ministry to do courses for radiation protection officers. All right, we are now looking at the standards and the requirements for each dentist, right? Each dentist has to become a radiation protection officer, especially those in the private sector. So this is very important, and now the standards are being created, and future we'll have the questions and so forth and the training. So that is quite good because every dentist will have to become a radiation protection officer. Right? This is the development that has been taking place in MASA as far as radiology is concerned. Now, we have not only done for local, but also for international, where we have been invited to give lectures, and this is in Cambodia. So the University of Pudisastra, which was, and this is the Dean, Prof. Callum, he invited me, and we have also tried to help out for those in disadvantaged countries as far as radiology is concerned. Right. Now, let's come to the subject matter, as today's thing is on clinical application of CBCT. Now, November 1895 was when Wilhelm Conrad Röntgen discovered X-rays. I think most of you know this was the place, and this was his wife, and the hand of his wife was the first radiograph that was ever taken. Right? So this was the first radiograph that was ever taken. And of course, in January 12, 1896, so just imagine within 2 weeks of announcement of X-rays, a dentist, all dentists are always very curious. So he did the first radiograph. So his name was Otto Welkoff. And what was great about this guy was he had 25 minutes exposure, right? So you can imagine how much of exposure he had just because of the X-ray. But the thing is, it was a challenge for him to find out the use of X-rays in the mouth, right? So 25, nowadays we do 0.32 seconds, whereas 25-minute exposure is quite high, right? So that was the exam, and this radiograph is somewhere stored in New York, for people to see. So the first radiograph, dental radiograph ever to be taken. Now, you see, in 1910, right, already people were looking not only two-dimensional, but three-dimensional, all right? And this was Dr. Clark. Dr. Clark wanted to do what you call as horizontal tube shift to look for an unerupted teeth. So you see, in 1910, almost a century ago, people were looking at the third dimension, not only two-dimension, but also the third dimension, right? Now, this is very, look at that is actually the principle called Parallax Method, all right? Where if you look at it, we did a study and we put a structure on the buccal side and then took a radiograph, all right, moving this way, and then the same structure, we put it on the palatal side, and then we took the radiograph in the same direction. Now you can see when you put the structure on the palatal side, and you move it this way, the structure on the palatal side follows. Whereas the subject on the buccal side, all right, when the X-ray cone is moved this way, the object goes on the opposite side. Now, this is what we have been doing in endodontics, right? This was what we were doing in endodontics. Now, this is what everyone was talking about, slop technique, which is actually the parallax method, and buckle object rule, Clark's method, and finally there was something called Richard's method. Richard's method is, instead of doing horizontal, he did vertical movement. And even then he found that the palatal structure always moved with the cone. All right. So whatever is on the palatal side always moved to the cone. Now, later in 1959, Dr. Petro designed the first panoramic machine. All right, first panoramic machine. Now, could you do the parallax technique using panoramic image? All right. So now the question comes whether you can do it. Now, if you look at it, the panoramic image is coming from the back, whereas the intraoral is in the front and the occlusal is also from the front. Now, if you look at this, when we do localization, when you consider localization using panoramic technique, you must consider as if you're shooting 7 degrees downwards. That is what we found as radiologists, that you got to do it as 7 degrees downwards. So you can combine panoramic with occlusal or panoramic with periapical. So when you combine panoramic with occlusal, now you got this, when panoramic. Now can you see occlusal? See the impacted tooth. There are 2 impacted teeth here. It has gone upwards. So this shows that is on the palatal side. All right. Now we did this test also here. All right. Now you can see that, the panoramic radiograph, you can see it here. When I did the occlusal, it has come downwards and on the buccal side. And when I did the the CBCT, I can see the crown is on the buccal side. All right. So this endorses the parallax method as a correct method as far as imaging is concerned, where we want to see the third dimension. Right? Now, if you look at it, in 1996 was the first machine that was produced for dental cone beam CT. All right? This was in 1996 and the machine was Newton and it was produced in Italy. All right? But unfortunately, the machine came like a normal medical CT machine. Okay. So what happened is it was not very popular. Then later they did develop the standing positions and the standing positions, and other machines came out with the sitting positions. So you have many machines now that has been produced, and you got almost like about 30 to 40 machines in the market now, right? Now, if you look at the CBCT, it was initially called as cone beam volumetric tomography. Later, it became called as dental computer tomography, and finally, it became cone beam CT or cone beam 3D imaging. It was initially used as for respiratory, cardiac, breast imaging, and also craniospinal surgery. Now, it is used X-rays in pulse mode. So that means if you have 20-second exposure, but the patient is only exposed to about 3.5-second ionizing radiation, right? So it is very, very good because very low radiation on the patient. All right. Now you got conventional medical CTs that are used by the medical practitioners, but when we compare with the dental CT, you have lower equipment costs. All right. Then you have lower patient radiation dose and also a smaller footprint. Now, for smaller footprint means it is a smaller machine. Now, this was an issue when I first bought this CBCT machine in Malaysia, when they said that it should be treated as a medical CT machine. All right, medical CT machine, because they said, look, it's a computer tomography machine, so it must follow the same medical. But then I managed to convince the Ministry of Health, and they said, look, this can be used just like a panoramic machine, because the radiation dose on the patient is very much less. And they agree, and that is why dentists can buy this machine and place it in their own clinics. Now, this machine has been used not only for surgical cases, but also for diagnostic purposes, and also most importantly for implant imaging. Right? Now, it's a volumetric data set. Okay, I'll talk to you about all this, where you have multiple sequential planar projections. Right? So I'll show you the details as we go along. Now, this is what I was telling. There are many machines, but I can't go into details. There are about 30 to 40 machines around the world that are being produced, right, with various parameters. It can be in a sitting position, all right, or in a standing position, whichever you prefer. And you must also look into the type of detectors that are being used, all right. It can be an IIT detector or flat panel detector, all right. And nowadays we have CMOS, what you call as complementary metal oxide semiconductor. And a lot of efforts are being taken on this as far as the detectors is concerned, because our detectors cannot detect soft tissue. But they are developing some new techniques, hoping that we can look at soft tissue. Right? Another thing that you must also consider when you're buying a machine, whether it is wheelchair friendly. All right, that's also very important for you to know. How does your machine work? You see, when you position the patient in the center, the X-ray source goes around the patient. So there is X-ray generation, X-ray detection, which is a sensor here or the detector here. And then finally, you got image reconstruction taking place. Right, so this is how it is done. Now, the trajectory comes like this. So this is a detector, and then sometimes they say this is an area detector and not a linear detector. Now, when you have an area detector, there is some compromise on the quality of the image. Unlike the medical CT is a linear detector. So this is where the quality may be a little bit compromised because of the detector. Now, you can see here, the medical detector here like this, it goes like a fan shape, and it is a linear detector here, whereas we got a area detector. And can you see the shape of the X-ray beam? It is cone shape or cylindrical in shape. So this is one of the reasons sometimes it affects a little bit on the quality of the image, because there is scattering of radiation. All right. So rotation exceeds 180 to 360 degrees. And what happens is each time it records one image. So the image is recorded in the form of frames. All right. Frames. Each shot, as the X-ray source goes around the patient, there is a shot that takes place, and that is called frames. Or sometimes they use the word basis images. So there can be 100 to 600 basis images according to the machine. All right. Now, once it is recorded, the basis images are recorded, it undergoes primary reconstruction. All right. Primary reconstruction. And finally, you have this image on your monitor, which is your orthogonal images, which we call as straight images, where you got sagittal, axial, and coronal image. So this is called orthogonal images. Now, there is a field of view, also very important. The smaller the field of view, the better, all right, for the image quality, because there is less scattering and less area where the detector is involved. So it all depends on the type of field of view that you require. My colleague, Dr. Manzoor, will talk to you about the field of view. All right. And with the patient preparation, you must always remove any jewelry. That apron must be used with probably thyroid collar, but it not affect the X-ray source. All right, where the X-ray is, the region of interest. That is very important. And also you must determine the voxel size. before you scan the patient. All right, different machines have got different voxel size. Now you can see this is a small area scan. Sometimes they use the word focal scan. It's only about 5 cm by 3.8 cm. Nowadays they say they can even have scans about 3 cm. 3 cm means you can only have 2 teeth, which is very good for endo and less radiation on the patient. Right? So this is your orthogonal images. And also you must buy machines according to the number of bits. Now bits is with regards to digital images. Now you can see the highest bits as far as the CBCT is concerned is 16 bits or 65,000 levels of grace. Now the higher, this is the highest so far as the CBCT machine is concerned. All right. So higher the bits, the better the quality of the image. Another area where it shows the orthogonal images. All right. So you can see the orthogonal image of the antrum. Now the other thing is you must also understand, okay, when we do CBCTs, we can get it's like this. If you look at the panoramic image, all right, A, B, C, D is already put together like this. But in the CBCT image, you can isolate C, you can isolate B as sections. So that it becomes very useful when we do want to study. Like here, you can't see what the impacted tooth is, but here you can see the impacted tooth very clearly. So this is the importance that we have as far as CBCT is concerned. Now, sometimes when you take your radiographs, you have not taken it properly, but the machine can improve the position of the image. So all machines have this. So that's not an issue. Now, I told you about voxel size. Now, voxel is this building blocks of the image, the small pieces here. All right. Now, what is voxel? Volumetric pixel is voxel. That means you got the third dimension. All right. So that is very important for us. So you can see, you can record a head with all these voxels here. Now, what is the advantage when you have voxels of this nature? That means I can cut in any direction I want and create an image. I can create planes. I can create oblique. I can create trans-sectional, cross-sectional. I can straight longitudinal. Any direction I want, I can make. So this is something that is very important for us when we want to do diagnostic imaging. All right. Now, medical CTs, they have anisotropic, whereas dental CTs has got isotropic. Now, if you look at the voxel size, the smaller the voxel, the better the quality. Now, if you can go like here, you can see the CBCT detection of MV canals increased from 60% at 0.4 mm voxel size to 93% at 0.125. Now, this voxel size has gone down to 0.05 mm, which is very, very 5 microns. Now we say instead 5 microns. That means we expect a quality like this on your image, which is very good for the endodontics, looking at root fractures and so forth. So this is the kind of quality that we need. Now, some machines have nowadays started allowing us to use for volumetric studies. All right, now you can see if you have that in your CBCT machine, you can get the curvature of the canals and you can also look at the thickness of the pulp canal. Now, for me as a forensic dentist, we have done studies looking at this volumetric. You know very well with age, the volume of the pulp cavity shrinks. All right, we are using that as a criteria for age estimation, and we have data for this. And we find the central incisor is the best tooth for aging a person. So I know we are doing that kind of work because we have machines like this that can produce results. This will give you the volume of the pulp cavity of the tooth, which is very important for us. Now, this is a Kodak 9000, one of the machines I used to work on. It uses CMOS sensor. You see the bit grayscale is quite good, 14, and the voxel size was 76 microns. All right, 0.076 mm or 76 microns. And it used to take a small area, so I used to get good images as far as the small area is concerned. See the radiation of region of interest. Radiation is very low for the patient. All right, and it is, you can use it. And sometimes machines have got this function where, although you got a small area, you can stitch it or blend it. All right, so that's a very good advantage that we face. All right, and you can do any image in any direction you want, and this is what we call as non-orthogonal, and it comes under multiplanar reformation. Multiplanar reformation, when you look at your machines, you will know that. Right, so that's the thing. So you have all these cross sections you can do. Now you can also improve the quality of your image, all right, by multiplanar reformation and also volume rendering. Now for volume rendering, there are two types of volume rendering. One is direct volume rendering and the other one is indirect volume rendering. Now, if you look at this image, you got bone, you got soft tissue, you got all this fat and everything in that image. Now this whole thing is called ray sum effect, all right? It is like a lateral skull radiograph. Now I don't want the soft tissue. I don't want the air. I just want the hard tissue. Now this is called direct volume rendering, all right? And you can see I get only the bone, okay, which is good. So I can look at any fractures, condylar head, and so forth. Now this is a case that I did for a patient. Now you know very well there is a maxillary sinus, that kind of opacification here, but I wanted to see whether there is any calcification. And all I did was to do the MIP or the direct volume rendering, and I can see there is calcification. And this patient after treatment, was okay. And that's the value of this MIP. Now, indirect volume rendering is done by the computer itself, and sometimes it can give you the soft tissue outline. All right, you don't have to worry about it. Sometimes you can segment it and see only a certain area. But that is done by the machine and you don't have the control over it. Filters are sometimes used, all right, to improve the quality. Now, in terms of effective dose, you see now already it has come to 5 microsieverts, which is comparable to 1 PA film, all right, periapical film. So this is the importance of this CBCT machine. So if you're doing RCT in a small FOV, you don't have to take probably a intraoral radiograph. You can straight away go for an FOV which produces 5 microsieverts, right? Now you can also see the difference thing. I mean, 1 microsievert, I mean, if you look at it, 1 CBT scan maybe is only 2, or what you call probably 2 hours travel by in flight, all right? So this is why the CBCT machine is quite good nowadays, and probably it will be, I mean, it won't replace the intraorals, but it can be used in terms of certain procedures where you don't need to do intraoral radiography, all right? But there are problems with this machine, okay? Because of low radiation and the cone beam geometry, you can see sometimes the quality is a little less than the medical CT, all right? And there are some artifacts because of scattering, all right? And the quality damages. And also there is something called cone beam effect. You must make sure the area where you want to see must be in the center where the cone, not at the periphery. This part will not be exposed to radiation. And when that part is not exposed to radiation, your quality, there will be artifacts. So these are the issues that you have. So the best quality will come around this area here, as far as the CBCT machine is concerned. And there is aliasing artifacts where, if you have a structure here, this structure will be passed here, but this part is not exposed to radiation. So you got images like this, all right, which is not very good. Okay, so that is the problem that we have. Now, there is also some artifacts because of procedures. Now, undersampling, that means you have only probably 100 basis images, but if you have increased to 600 images, the quality would have improved. So that is undersampling. Then also misalignment in the detector. This one you have to get the vendor to come and to see. And the last one is your patient movement. All right. So you can see patient movement. You can see that there are two lines, and that's very important for you to detect. Now, there are some other artifacts which are called introduced artifacts. And this is because, so you can see there are something called beam hardening, all right, and streaking that has taken place. This is because the metal restorations have absorbed the radiation, all right. So you have introduced artifacts. Now, the other thing is, you see here, an artifact below a filling, all right. This is what we call as photon starvation or extinction artifacts, because the X-ray it was not exposed here, because it's absorbed here and absorbed here. So it looks like as if you got secondary caries. All right, you must be very careful of this. Another one that can happen is like this on the image, and that we call it as beam hardening. All right, you can see like I see we got an extra canal. Okay, so that's the thing. This is scanner related artifacts. All right, all these are scanner related. Something wrong with your scanner. Now, what are the advantages? I'll just go briefly on the advantages. You got a small size machine. Image accuracy is very good, especially when you have a voxel size which is less than 0.076. Scanning time, very fast, 10 to 70 seconds. Dose reduction, very low dose. And also you can use your personal computer to for interactive analysis, right? The factors to consider as a disadvantage is it is expensive, but it is coming down. The prices are coming down because now the sensors have become cheaper. They're using CMOS sensors. CMOS is very much cheap, so you can get it quite okay priced. No movement of the patient. Image noise because of scattered radiation, because we're having it in a cone form and not a linear form of thing, a linear radiation, and because of that there is a lot of scattering. So that is why image noise is higher. Poor soft tissue contrast. Now we have to improve on this poor soft tissue contrast. The reason being is our detectors can CBCT is only up to about 16 bits technology, whereas medical CT can go about 24-bit technology. That is why in medical CT you can see the soft tissue, but the dental CTs you can't see soft tissue. And of course, lastly, it is a learning curve for the dentist. All right, now I'll stop my lecture here. This is a case of a clinical finding, which is it's one of the second case that where there was destruction of bone due to dengue. All right, now I don't know whether COVID got any effect on the maxillofacial region. So now I will finish here and pass on the mic to my colleague, Dr. Manzul, to talk about the clinical applications of CBCT. Thank you very much.
Yeah, thank you so much, Prof. Prabhakaran, for your interesting presentation. And then thank you so much for enlightening us with the applications of CBCT in clinical dentistry, especially in forensic odontology and even in the clinical endodontics. So we have a few questions for today evening, but we will try to answer them after the second presentation. So now I would like to introduce our second speaker for today's evening, Dr. Satik Mansoor. So, Dr. Satik Mansoor got his master's in dental surgery in oral medicine and radiology from Raja Muttiah Dental College, Malaya University, India. And currently, he is working as a senior lecturer at Masa University. He has more than 8 years of teaching experience in the field of oral medicine and radiology. And he is a member of many national and international oral medicine and radiology associations. Currently, he is doing research project funded by Masa University, and his research interests are in the field of advanced imaging, dental age estimation, oral cancer, and he has authored many peer-reviewed research articles in various national and international journals. He has organized and actively involved in many workshops and conferences for the dental faculty like CBCT workshop, Panoramic workshop, advances in optical diagnostics and surgical soft tissue imaging workshop, and case-based oral mucosal lesion workshops in Malaysia. So without any delay, I would like to welcome our speaker for today, the second speaker for today, Dr. Satik Mansoor. Over to you, Dr. Satik Mansoor. You can share your screen. Yeah, I'll just share your screen. Then you can start with your presentation.
Thank you, Dr. Raghu, for the wonderful introduction. Prof. Prabha was briefly described about the CBCT missions and acquisition of images, advantages, disadvantages of the CBCT mission, and also he mentioned about the latest technologies available in the market. So today I am going to talk about the clinical applications of the CBCT. I'm going to focus some interesting cases which leads to the diagnosis with the help of 3D imaging. CBCT technology is widely used in the dentistry, which includes oral surgery, endodontics, periodontics, orthodontics, and pre-implant planning. CBCT is basically a 3D imaging. It can be applied when 2D image does not provide enough information to arrive at diagnosis or for the treatment planning. Prof. Prabha mentioned earlier about the field of view. There are different types of field of views that is called as FOV. There are different types of FOVs are available, which ranges from 3 by 3 to 15 by 10. That is the latest one is the 15 by 10. So we can select the FOV depends on the patient's needs. For example, if we are doing endo cases, it's better to go for the 4 by 4. Or if you want to rule out any cyst and tumors or the extension of the tumors or the cyst, it is better to go for the higher FOV. So when we go for the lower FOV, we have two advantages. Number one, we can minimize the patient radiation dose to the patient. And number two, better quality will be achieved by using the smaller FOVs. So I'll move on to the next slide. See, when we have a wonderful 2D imaging like orthopantomography, why do we need a 3D imaging? The image that is the image that is seen on the screen is the orthopantomography, that is OPG. It is the most favorite radiograph for all the dentists, which provides the lot of information, which includes the maxillary and mandibular teeth in the single arch, mandibular condyles and inferior border of the mandible, etc. Many lot of information we can achieve from this 2D imaging. Then why we need a 3D imaging in the practice of dentistry? See, there are two disadvantages in the 2D imaging. Number one, superimposition of the images, and number two is the distortion and magnification. Because of these two disadvantages, we compulsory need a 3D imaging in the practice of dentistry. Okay, see, look at this. There are four different objects are located in the space, and it is oriented at the same plane. When it is exposed by an X-ray, all these structures are overlapped and compressed in the 2D image. In case, if we want to see the shape of the each object, shape and size of the each object, it is impossible to rule out from the 2D imaging. Exactly the same thing happens in our skull bone. There are a lot of structures present in the skull bone. When we expose the radiation on the 2D imaging, it is impossible to get the exact size and shape of the each structures. That's the importance we need an 3D imaging in our daily routine practice. One example I will show you. This is a patient reported with a pain in relation to the 2-6. So we took an IOPA for this patient. There was a tender on percussion. Then clinically we provisionally diagnosed it as some periapical pathology. So we took an IOPA for this same patient. But there was no evidence of any periapical pathology in this patient. So we referred this same patient to the CBCT imaging, and we found out that there was a periapical pathology in relation to the 2-6. This is because mainly due to the overlapping of the multiple structures, the periapical pathology was hidden behind the tissues. So that's why we need 3D in our regular dental practice. The second disadvantage, what I was told before, is the magnification and distortion. There was a study conducted in 2016, and they compared the dimension between the OPG and the CBCT. And what they have done exactly is they measure, the first image is the panoramic image, and the down are the different sections of the CBCT imagings. Okay. What they have done in the study is they measured the length and width of the tooth in the OPG and also on the CBCT imaging. So they found out that there is a increase in the length and width of the anterior tooth in CBCT when measured with the OPG. Exactly the same thing they have done on the posterior tooth. Posterior tooth slightly decreased than the anterior length and the width. So what they have concluded in this study is it is impossible to tell the accurate length and width or any size of the structure by the 2D imaging. So they have concluded that it's 100% with 100% accuracy. We cannot say the exact length and width of the tooth or any other structures present in the maxilla or mandible. That is the importance of the CBCT in our clinical applications. So I will move on to the applications. How much it is helpful in the in few cases like in implants and other faculties. So in implants, to improve the overall success and to reduce the surgical and prosthetic complications, definitely we need a 3D imaging. Okay, only the technical skills does not sufficient to place the successful implant. With the help of 3D imaging, it is possible to place the successful implant in the long-term practice. So the goals of the implant imaging. So when we go for the implant imaging, 5 factors should be considered, and all these 5 factors can be assessed through the CBCT imaging. First one is the bone dimensions, because the bone dimension is going to determine the implant length and the width. So the bone height is going to determine the implant length, and the bone width is going to determine the implant width. Next one is to assess the bone quality. The primary support of the implant is going to determine the stability of the implant. The primary support is going to stabilize the implant. Third one is to identify and localize the internal anatomy to make sure that we should not traumatize the vital structures which is present in the maxilla and mandible that can be identified through the CBCT imaging, and also to establish the jaw boundaries, and lastly to detect any underlying pathologies which is associated with the tooth or anything. For example, if we are going for an implant, we need to assess the bone quality or any other underlying pathology. If there is any fiber dysplasia or Paget's disease, there is no chance of osteointegration in that area, and there is no point in going for the implant placement in that particular area. So I'm going to show you how we can measure the height and then height, width, and how to assess the bone quality in the further slides. So first is, as I told you before, bone height is going to determine the length of the implant. So it should be measured from the crest of the alveolar ridge to the opposing border of the bone, or to any anatomical structures. So they have divided into four areas: maxillary anterior, posterior, mandibular anterior, and posterior. For maxillary anterior and posterior, this is the cross sectioning of the image. If you see that, we can able to see the crest of the ridge and also the inferior border. This is the nasal fossa, and we can able to appreciate the inferior border of the nasal fossa. So the measurement should be made from the crest of the ridge to the inferior border of the nasal fossa when we are placing the implant on the maxillary anterior region to determine the height. For the maxillary posterior region, we should measure. This is the maxillary sinus, the cross section, sagittal cross section of the image, and this is the maxillary sinus. We need to measure from the inferior border of the maxillary sinus to the superior border of the crest of the ridge. So when we are placing the implant on the mandibular anterior region, again we have to measure from the inferior border of the mandible to the crest of the ridge, and for the mandibular posterior region, we have to measure from the inferior alveolar canal to the crest of the ridge. This is going to determine, this is very important, and this is going to determine the implant length. So next is the implant width. The implant width is determined by the bone width. Bone width is measured from the buccolingual width of the alveolar bone. Buccolingual width of the alveolar bone. So this is your buccal bone and this is your lingual bone, and in between there is a trabecular bone, and under to that there is a inferior alveolar canal. So all these factors should be considered when we are measuring the buccolingual width to determine the implant width. Okay, for in the 2D imaging, at least we can able to assess the bone height with slight magnification. Almost 20% magnification. There are study proved that the 2D imaging has the 20% magnification. So by intraoral periapical radiographs and also with the OPGs, we can able to determine the implant height. But in the 2D imaging, implant width is not at all possible, and we need an uh, 3D imaging to determine the buccolingual width. So number 3 is the density assessment, bone density assessment. Bone, I told you before, the density of the bone is going to determine the primary support of the implant. The primary support of the implant is determined by the density of the bone. So there are two ways to see the density of the bone. Number one, by using the Hounsfield unit, by using the software. Number two, there was a classification given by the mission Judy. So number one, how to identify the density of the bone. So when you click the, there is a software. So when you click the mouse on the particular location, it will show the Hounsfield unit of that particular location. So with that help of Hounsfield unit, we can able to identify the density of the bone. This is not the 100% accurate method because there is a difference in the values. So we have one more method to determine. Mish and Judy had classified this as a D1, D2, D3, and D4 type of bones. There are different types of bones. There's a D1, D2, D3, and D4. D1 is the dense cortical bone. D2 is the outer cortical bone is thick and the coarse trabeculae bone. D3 is the thin cortical bone with the fine trabeculae, and D4 is the thin outer cortical bone. The most suitable area to place the implant is the D1 and the D2 bone. This can be assessed through the Hounsfielding unit or by appearing the CBCT images in different slices, different cross-sectional slices. So the next most important thing is that we need to assess the anatomical structures present in relation to the implant placement. So when we are going to place the implant on the maxillary anterior region, the only vital structure we should consider is the nasopalatine canal. This red arrow is indicating the nasopalatine canal in different sections. Actually, you can see in all the sections of the CBCT imaging. This is the axial section and this is the coronal sections. In the sagittal section, cross-sectional slices, we can able to identify the nasopalatine canal. And also, if you go into the cross-sectioning of the image, on the palatal cortex side, you can able to see the radiolucent line, which is traveling from the periapex to the crown, and it's opening through the palatal cortex. So this case, if you look at this case, the implant is impinging on the nasopalatine canal that leads to the permanent numbness of the patient. So it is very important to consider this location when we are placing the implant on the mandibular anterior region. Number two is the maxillary posterior region that is called as the sinus zone. The minimum bone should be it's measured from the inferior border of the maxillary sinus to the crest of the ridge. The minimum it should be 6 to 8 millimeter to place the implant. If it is less than minimum 6 to 8 centimeter, then it is necessary to go for the sinus lifting by placing the bone grafting. This picture shows the sinus lifting case, and this shows the sinus lifting, and it creates the room for the placement of the implant. And the functional zone third is the most important zone that is called as the mandibular anterior zone. In the mandibular anterior zone is considered from the left mental foramen to the right mental foramen. Two important things we need to consider here. One is the mental foramen and another one is the incisive canal. So mental foramen we can assess through the different sections of the CBCT images. This is the axial section. You can see the radiolucent dot which exits through the mandibular bone, and this is the case reported. If you see the orthopantomography image, it looks very perfect. The implant looks very perfect. Then we took a CBCT for that particular case. There was a lingual uh, perforation of the implant placed on this patient. So look at this image. Uh, when we are placing the implant on the anterior region, we have to consider the long axis of the implant. So if you perforate on the lingual side, it leads to an emergency, and because of the sublingual hematoma, it damages the incisive canal which is present lingual to the tooth. Because of that, the patient ends up in an emergency, and it causes the subdural hemorrhage. This is the axial section of the CT, which shows the uh, perforation of the implants and also the sublingual hematoma. So how to assess these incisive bundles? So when you go into the cross sectioning of the images, when you go into the cross sectioning of the particular tooth, you can see the radiolucent line runs in between the outer cortical bone. You can notice very carefully. In some cases, it appears as a very wide canal. If it is very wide, we have to be very careful in assessing in placing the implants. Functional zone 4 is the mandibular posterior region. Mandibular posterior region, the main factor we have to consider is the inferior alveolar canal. So we have to measure the distance between the inferior alveolar canal and the placement of the implant. And also we have to clearly look for the bifoot mandibular canals. In most of the cases, the bifoot canals were reported, and you have to consider of bifoot mandibular canals. And the last one about the implant is the 3D virtual implant planning. There are different types of softwares are available in the market, but even though there are a lot of softwares, we should have the thorough knowledge to relate with the anatomical structures and also about the measurement by using the different slices of the computerized tomography. Okay, I will move on to the next most important topic is the CBCT in endodontics. In our normal dental practice, we 90% of the practitioners use the intraoral periapical radiograph for the root canal treatment or any endodontic procedures. When the CBCT comes into the picture, when the patient is having a pain after the successful endodontic treatment or any complications during the procedure. So in these situations, the CBCT comes into the picture. So I will show you some indications and usefulness of CBCT in the endodontics. If you look at this radiograph, if I want to do the root canal on the 1/7 in relation to 1/7, I couldn't able to appreciate the morphology of the tooth. So if you are not able to appreciate the morphology of the tooth, I strongly recommend you to prescribe for the CBCT to rule out the exact morphology of the tooth. In this root, I cannot appreciate the morphology as well as the root is fused or it is a single root. We cannot see anything from this radiograph. Okay, so if you are not clear with the tooth morphology, it is better to go for the CBCT imaging. Number two is when you see this is the premolar region, and there is a radiolucency in this radiograph. Now there is a confusion is in most of the time the mental foramen will be projecting on the premolar periapex to the premolar tooth. So if you have confusion in coming to the diagnosis or to relate to the any anatomical structures, it is better to go for the 3D imaging. And the third most important is the fracture of the tooth. The fracture of the tooth is 90. There are a lot of studies stated that 90% it is impossible to find on the intraoral periapical radiographs or any 2D imaging because of overlapping of the structures. So if you look at this radiograph, there is a fracture on this particular tooth, but it is not evident on the intraoral periapical radiograph. In the same patient, we can see the fracture line clearly on the CBCT imaging when we move on to the further slices. Okay, number four, the most important indication is that identifying the root canal morphology and also the remaining canals present. Most of the case reported with two canals in the anterior tooth. This is the mandibular anterior tooth, and you can see the two canals which is present. We thought that it is a single canal, but most of the case reported with the two canals. And the last indication, the most important, is the resorption of the tooth. When it comes to the resorption, if you see the intraoral periapical radiograph, we cannot appreciate whether it is an internal resorption or external resorption. Or if you want to rule out whether it is an internal resorption approaching externally or external resorption approaching the pulp, it is easy to identify through the applications of the CBCT imaging. Okay, then these all leads to the diagnosis and also for the proper treatment planning. I will show you some important cases, interesting cases, which leads to a diagnosis by using the computerized cone beam tomography. This patient was having a pain in relation to 2/6 after the successful endodontic treatment. So if you look at this radiograph, the obturation wise, it looks very perfect, but there is a periapical radiolucency. So we thought that what is the reason for the periapical radiolucency? Then we took one more radiograph with the slight change in the angulation, and we observed that there was a radio opacity present in between the tooth. We are not sure about that radio opacity, whether it is a root or any other structures located in that particular area. So we prescribed that same patient for the CBCT imaging, and we identified there was a one more canal present on the same tooth, and that leads to the periapical infection. So we found out the canal and the obturation done, and the patient was fine. This is the post-operative radiograph after 3 months. We can see the bone formation clearly in this radiograph. So these are all the usefulness in identifying the remaining canals on the tooth. This also an interesting case. What we have come across is that this was the patient premolar root canal treated tooth. The obturation is perfect, and still the patient was having a pain and the periapical lesion. Here we had a confusion that whether it is a mental foramen is projecting on that particular area or it is truly a periapical lesion. So we prescribed this patient for the cone beam computerized tomography. Then we identified one more canal was present on the premolar tooth, and we identified the canal and the obturation done, and the patient was fine after the retreatment. One more, this is also a very good case we had come across. If you see, the patient was complaining of pain on the 1/6 region. So we took an IOPA. I did not put the IOPA here, but we took an IOPA. Nothing was evident on the intraoral periapical radiograph. But the patient was having a dull aching pain for the past 4 months. So we took an OPG to rule out further. OPG was also not helpful because it was not, we ruled out the maxillary sinus, we ruled out the bone pathology, everything was perfect on the OPG. Then we prescribed the same patient for the CBCT. So when we went for the CBCT, the first image, this is the 3D reconstruction, the 3D panoramic reconstruction, and this is the sagittal section and the cross section and the axial section of the images. So when we go into the cross section of the images, we found out there was a oblique fracture, root fracture on this tooth. This is definitely impossible to find out in the intraoral periapical radiograph. Finally, we identified the fracture and we extracted the tooth, and the tooth has been sent for the extraction. These are all some interesting cases we had come across. So if you come across all these type of findings, or after the successful endodontic treatment, if the patient is still having a pain, I strongly advise you to go for the CBCT imaging to rule out the further investigations. The next most important during the endodontic procedure is the broken instruments. See, if you see this intraoral radiograph, we can able to see there is a broken instrument, we but we cannot appreciate whether it is placed buccally or lingually or in which direction. It is important to know the direction to retrieve the broken instrument. So if you apply a CBCT, you can find out whether it is buccally placed or lingually placed or or it is in which direction. So it gives the pathway for the retrieval of the broken instruments. Next is the perforated canal. In case of perforated canal, it is very difficult to identify because of the overlapping of multiple structures in the intraoral periapical radiograph. So we prescribe the same patient for the CBCT. Then CBCT we can able to clearly identify there is a perforation of the root. Next is the root fracture. I told you before, it is impossible to identify from the intraoral periapical radiograph. So when we do the cross sectioning of the image, we can able to identify the fracture clearly. Next, we are moving on to the CBCT in oral surgery, applications of CBCT in oral surgery. CBCT in oral surgery comes into the picture there for the third molar, evaluation of the third molar, impacted tooth, sinus pathology assessment, TMJ evaluation, and also for the to rule out the extension of the cyst and tumors. Okay, first we'll see the third molar evaluation. In the 3D panoramic radiograph, we have to draw using the software. We have to draw the inferior alveolar canal by using the software. So once you have drawn, when you go to the transaxial or multiple cross-sectional views, we can able to measure the distance between the impacted tooth and the inferior alveolar canal or the mandibular canal. This helps the surgeons to extract the tooth without any serious complications. Next is the impacted tooth. Impacted tooth is important to send for the when there is a multiple impacted tooth. I always suggest you to go for the CBCT because we can able to identify the exact location of the tooth and also whether the tooth is placed buccally or lingually or the tooth is inverted. All these findings we can find out in the single rotation of the CBCT. Look at this patient, the tooth, this is a supernumerary tooth, this is impacted, this tooth is impacted and it is located below the orbital rim. So when there is an impacted tooth, it is always better to go for the CBCT imaging. So this is the cross-sectional, this is the axial section of the CBCT. So we can able to see clearly whether the impacted tooth is placed buccally or lingually. Next is the sinus pathology assessment. Sinus pathology assessment we can able to see on the 2D radiographs, but if you want to really know the content of the sinus, it is not possible in the 2D radiographs. To know the content of the sinus, it's better to go for the CBCT imaging by using the Hounsfield unit, whether it is a fluid or pus or any tissues placed in the tooth or any calcifications. It is easy to identify by using the 3D technology. Cyst and tumors in oral surgery. See, exact measurement of the cyst and tumors can be measured by using the CBCT, and also we can able to assess the relative anatomical structures in relation to the particular tooth. So these are very important to measure the exact size and structures and also the vital structures to plan a complication-free surgery. Next is the maxillofacial trauma. In 2D image, we cannot really say whether the trauma is associated with the buccal cortical plate or with the lingual cortical plate. So for the same patient, if you take an OPG, we can see the fracture, but really we cannot appreciate whether it is a lingual fracture or buccal fracture. But in 3D directions, we can able to appreciate the fracture whether it is present on the buccal side or on the lingual side of the bone. So assessment of the health of the TMJs. This is the normal TMJ, and the second image which is showing the erosion of the TMJ, and here you can see the extensive erosion of the TMJ, and the last one is the tumor. Some tumor is associated with the benign tumor is associated with the TMJ. So to rule out the TMJ, I suggest you to go for the 3D imaging. Next, coming to the CBCT in orthodontics. In various fields of orthodontics, the CBCT can be applied nowadays. Actually, most of the most of the orthodontists are basically relied on the 2D lateral cephalograms. Now there is a 3D lateral cephalograms. By using the software, we can analyze we can do the cephalometric analysis by using the software and also with the report. The next most important factor in orthodontic is that to bring the impacted canine into the arch. To bring the impacted canine into the occlusion, we need to identify whether the tooth is impacted tooth, the location of the impacted tooth, and also the tooth is placed buccally or lingually, or the tooth is inverted, or the impacted tooth is associated with any root resorption, or it is causing any tooth displacement. All these factors should be considered when we are bringing the canine into the occlusion. So with in single rotation of the CBCT, we can be able to find out all these structures in the 3D reformatting. This is the case reported for the ortho cases. In the panoramic image, we can see the impacted canine here. So when we went into the when we go deep into the cross sections of the image, you can notice that there is a very minimal buccal bone present here. So it is very difficult to bring this tooth into the occlusion. So it gives lot of ideas to bring the tooth into the occlusion in case of orthodontics. And also it is useful for the mini implant site. In ortho, mini implants is used for the anchorage purpose. So to place the mini implant, we have to select the location. So by using the 3D imaging, we can select the exact density to place the implants on the particular location. And most importantly, for what they are using the CBCT is the cleft palate assessment. So in the cleft palate assessment, we can able to measure the extension of the lesion from where to where the cleft is present, and also relation to the nasal floor in the 3D directions. So before going to the graft, before planning for the graft, it is better to go for the volume. It is better to assess the volume by using the 3D imaging in cases of cleft lip and cleft palate. So the last one is the airway assessment in orthodontics. See the airway assessment is impossible in the 2D imaging. Airway assessment, if you see that this is the first one is the normal. This is the upper pharyngeal arch, and this is the lower pharyngeal arch. The first one is the normal. The normal is between the 22 to 24 cubic millimeter. If the airway is between 22 to 24 cubic millimeter, then it is considered as a normal airway. But the second image is showing the reduced airway. You can see the enlarged adenoids, which causes the constriction of the airway. So the constriction continues to the lower pharyngeal arch, and it is below 18 cubic millimeter. When it comes below the 18 cubic millimeter, we have to really concentrate on, we have to really plan for the braces to improve the airway. So in kids, it leads to an acute angle with the anterior open bite. The complication in kids is the acute and deep angle with the anterior open bite. In adults, it leads to the chronic obstructive dyspnea. So it is important to assess, and it can be assessed through the CBCT and the CT machine also. So this is the software which is using to measure the airway volume. Next, coming to the last portion of the presentation, that is the CBCT in periodontics. CBCT in periodontics, we can be able to assess the single wall defect, or it is a double wall or triple wall defect, and we can able to measure the exact measurement of the bone loss in all the different directions. And sometimes it is necessary to measure the soft tissues. Soft tissues also possible to measure, but not in detail. At least we can see the margin of the soft tissue. But if you want to rule out the soft tissues detailing, it cannot be done through the CBCT imaging. And also it is easy to identify the furcation involvement. If you look at this radiograph, the furcation is not clearly seen, but when we took the IOPA for the patient, we noticed the extensive bone loss and also the furcation involvement in between the two roots in the sagittal section of the CBCT. Here also in 3D dimension, it shows the same patient, it shows the furcation involvement in all the different slices of the CBCT imaging. So this is the last case in the periodontitis. So it's a case of generalized periodontitis. We can able to identify the extensive bone loss in all the directions. So with that, I conclude that CBCT application can be used widely in the field of dentistry, and it helps in making the diagnosis and for the treatment planning. Those days it was expensive to go for a CBCT, and now it become quite cheaper. And also we can select the different type of FOVs. According to the FOVs, the price is also cheaper. So if you want to rule out the single tooth, I always advise you to go for a minimum FOV. And if you want to rule out the complete structure in the maxilla or the mandible, better to go for the higher FOVs. So thank you for listening.
Yeah, thank you so much, Dr. Mansoor Satik, for your very interesting as well as a very informative presentation. You almost touched all the applications of a CBCT in each and every specialty of a dentistry. So I can see some few questions in the comment section here actually. So I would like to take up the questions one after the other. So we have a question from Wong Hong Zhang. So this question is asking to Prof. Prabha. So the question goes like this. So does voxel size or FOV affect radiation quality? That is, do smaller voxels and or larger FOV requires higher radiation? And how should we choose or compare the CBCT machines to purchase while we are purchasing the machines?
Okay, thanks, Dr. Raghu and Mr. Wong, Dr. Wong. All right, now it depends for what purpose you're buying the machine. Like if you are a general practitioner, Hong Sang, if you are a general practitioner, it is better to go for small FOV and small FOV and small voxel size. Then you can have for your implants, you can have for your RCTs and also for your third molar removals. That is enough in your GP practice. But if you are going into a faculty or a bigger setup where you do fractures and so forth, then you need a machine with a larger FOV. All right, like we had machines which are 22 cm. Right, and then it is very good for us to look at the whole skull. So it all depends, but I think a small FOV is fine for you, for a general practitioner with a small voxel size. Try to get small voxel size. That's very important because that's when the quality of the image improves. All right.
Yeah, I hope Wong Hong got his answer. So we have the second question from Tolok. The question is, with the accuracy of CBCT in most dental problems, should we skip the periapical radiographs? Thank you.
All right. Now the gold standard for caries is still periapical, so we cannot skip periapical. But if you are doing RCT and if we can get the one with the small FOV with the small exposure on the patient, fine. I think that should be fine. Maybe it might replace in the future. But at the moment, still periapical, you need it. It's a gold standard for caries detection for patients using periapical fluids.
Yeah. So we have a more question. The third question is, can we identify cracked tooth in the CBCT if the crack line haven't progressed into a fractured tooth?
Right. Now, that's a very good question, and I have been trying my level best to use the CBCT. I've used water in the image and all that. You cannot do it well unless you probably, they say now you can use a cotton roll, bite on a cotton roll and try to separate the piece together and then take a CBCT. That was the one that was, and then they used tooth sleuth. All right, tooth sleuth and bite and then try to separate the two segments, then take a CBCT, you may be able to detect the fracture. Otherwise, it is very, very difficult to use. Now, I don't know, because we have a small a small voxel size, maybe when we get the machine, we must try and see whether we can detect the fracture lines in the CBCT machine. If we can do that, then you have done something good. But at the moment, it is still difficult.
Yeah, I hope the quiz also going to answer. So these are all the questions for today's evening. So I would like to thank everyone for joining us for the today's evening presentation. So we will just keep you updated with our upcoming webinars, and stay tuned to Masa University Facebook page. And any concluding remarks from Prof. Prabhakaran?
If any questions they have, they can always contact us. As far as purchasing machines, or the type of machine they want and so forth, I think we can always help anybody who wants. They can contact Masa, and we can try to help them. It's not an issue at all, right? A lot of suppliers talk to us about their machines, so we have a collection of know which machines is good for which practice. So I think that's all we can help those who are interested in buying machines.
Yeah, so those who are interested in buying the machine, you can contact Prof. Prabhakaran and Dr. Mansoor Satik for the same. And I hope you all enjoyed our today's presentation. So with this, I would like to end the broadcast. Take
Thank
care.
you.
Yeah.
Thank you, Raghu.
Thank you,
Very much.
sir. Dr. Mansoor,
Yeah.
sir. So take care, stay safe, and see you all soon. Thank you. Bye bye.
Not bad, right?
Good.
Good.
Mansoor, sir.
No, this is first time I'm going online, Prof. I should have, no, some. I